Good morning, everyone. Today we're going to be covering essentially just a case study with an N of 1, myself. I had a kind of an interesting journey prior to coming to get the opportunity to speak to all of you today, so we'll go over more of that, give a little bit of flavor and putting more of the person into the patient. And then we're going to go cover some of the stuff that might be on the test. So first up, yeah, absolutely no disclosures. We're going to talk a little bit about my service, how I was injured, and a bit on my re-education and how I had to adapt to the environment post-injury. So as many of our stories started out, I had pretty humble beginnings. I grew up pretty economically disenfranchised. My parents were in and out of bankruptcy growing up, and opportunities for us were going to be, hard fought. So it's just my sister and I growing up on a small farm in the beginning. Parents were able to move us to a really excellent school district, but a pretty rough neighborhood within there. From there, I excelled in sports growing up and had several opportunities to go for scholarships, but that didn't really cover my sister. So my intention was to go to the United States Air Force Academy in order to send money back home so that she can go to school as well. Fun fact, on the flyer, they told us it was nearly $2,000 a month. So I was like, oh, this is great. I'll be able to cover my education and hers. Got my first paycheck, $60. And I'm like, man, math doesn't add up. And I asked, and they said that, oh yeah, it's $2,000 a month, but you got to pay for all the stuff we just gave you. So, but the opportunities were there. The Air Force was going to use me, so I figured I was going to do my best to get every opportunity I could from them. Classes were free, opportunities were vast. So I started off on the Air Force parachute team, got to travel the world, jump out of planes, picked up scuba diving there. I got a chance to play several intercollegiate sports there. So it was great. It was phenomenal opportunities. And it was kind of a cauldron for developing some of the best because we started off with 1,440 cadets and only about 700 of us graduated. So it was just dog eat dog the entire time. But strongest steel is forged in the hottest fire. So it was a good opportunity for me, helped me develop as a young man. From there, I was able to climb toward the top of my class and garnered a coveted spot into flight school. Flight school for me was a little bit different. Most people grew up like in aviation, or they had fathers that flew or something like this. I started off with almost no context for it, with the exception of sitting in the back of the plane jumping all the time. I never really had to work on landings and all that stuff, so it was fun. Not as dramatic as this, but it's always a little bit entertaining just to have the concept, because you're up there, in an environment you're not used to for the first time. So here's a young pilot, on his first checkout ride. I was taught by a man who was a Vietnam fighter pilot, and with about 8 hours of instruction, he goes, "Oh yeah, you're cleared for your solo. You got this down." I was like, "Yeah, it's great when you're sitting next to me." But as soon as he jumps out of the plane, I'm like, "Wait a minute, what were those things you just told me?" He wanted to set the record for one of the youngest pilots, or one of the solo pilots with the fewest number of flight hours. And here I was, up in the middle of the clouds trying to figure out what was what. But it's not that task saturating. You got tons of help. So my service was an absolute blessing and opportunity for me. I was fortunate enough to be able to serve my country in many different capacities. I went off to undergraduate flight training, was able to take an assignment to get me a lucky spot as I was accepted into graduate school at Harvard. Things were on the perfect path for me. I had some plans to potentially go into special operations, potentially go into more of the engineering development side, or potentially just stay as a career pilot. So the options for me were limitless at this point. And then the country was shooken up. After 9/11, everybody was wanting to put the fight back to the enemy and take all the war and put it on the away ground. And I was no different. So I chose to go into the combat rescue side. And for those that don't know, it's kind of the officer equivalent of pararescue jumpers. We are any environment rescue individuals, so we would go in and take anybody in a combat situation, medically treat them and get them out, whether that's up in the mountains, whether it's underwater, whether it's anywhere in the world. We would fly in, jump out, kill everything moving, treat the patients, and then wait for help. Somebody would come with a helicopter later and come take both me as the rescuer and my team and the individual that needed exfiltration out. After all the training, I was getting ready to redeploy out to Afghanistan, and the number one question that everybody always asks me, for whatever reason, it's the number one question that I can't answer. I woke up 2 months later with sparse details. I know that I was paralyzed. That was a lesson to me that it wasn't immediately obvious, because I woke up in a stretcher staring at ceiling tiles, and for whatever reason, I was handcuffed to a bed only to later find out that I thought that I was captured in war and that they were trying to, detain me and question me. What it turned out was all throughout my induced coma, I kept trying to rip out all the wires and tubes and all that stuff, thinking that I was some kind of a prisoner of war and they were holding me down. So once my family finally came, I was able to have some kind of orientation. And from what we can gather, it was some kind of a motor vehicle accident on base. It left me with the quandary of, what am I going to do next? Here I was with all this stuff to contribute to my country and to help out others. And here I had to take all that training that I had, put it to the side, and redefine myself as a young 24-year-old man. So what I did immediately was get into extreme depths of neurospinal rehabilitation. I started off as the pilot participant in all the exoskeletal walking systems. I was the pilot participant that got the FDA approval for these to be used, writ large, but also at academic centers. So I started off at the Kessler Institute, where we did bodyweight supported treadmill training. We moved on to automated systems and Locomat, and then eventually into these exoskeletal walking systems. All meanwhile, trying to advance the field, trying to help my own recovery, trying to help those that came after me, but I felt that I had a lot more to give back. I was very fortunate to have survived circumstances that I, quite frankly, should not have. They were giving me within hours to live. My family was immediately flown in, and they were by my bedside the whole time. I had collapsed lungs and hemothorax and all kinds of stuff going on, and I was tanking pretty quick. And luckily, by the grace of modern medicine, I survived. And I figured that my contribution moving forward, since I was given a second life, was to give back to the medical community that kept me alive all those years, maybe carry the torch and help the next generation. The only question was, how was I going to become, a medical care provider as a person in a wheelchair, dealing with paraplegia, trying to figure myself out with a background in engineering and aviation. I had a degree in comp sci and electrical engineering and took classes in astrophysics and aeronautical engineering, and it didn't really readily line up to me, so I had to re-educate. And as I had mentioned earlier, I was scheduled to go to graduate school, so I used my graduate education at Harvard to bridge the gap between engineering and modern medicine by going into bioinformatics. I figured this would get me, the resume I needed to get into medical school. All the meanwhile, I still had to figure out what it was like to be paralyzed and how I was going to move forward, how I was going to rehabilitate and keep my body healthy. So I got into any and everything I could, staying active, staying fit, trying to keep my body as well as I could, in order that if I ever was able to find some kind of a cure or work on new modalities, that I would be fit enough to be able to recover fully and ambulate again. So I started building my own wheelchairs. I didn't like what the VA had available for us, so I started welding and tinkering around, started a small company that was quite successful for a while, and enjoyed pretty much every activity you can imagine. I was never really shy from doing fun things, and that's kind of what got me into scuba diving and what put me back here. I loved diving, I loved jumping and all that stuff prior, but diving was the only low-risk one that I could enjoy post-injury, where I knew that I'd be safe and comfortable. I got a chance to meet Jim Elliott and Diveheart back in 2009, give or take, 2007 actually, and then went on my first couple of trips and had this great opportunity in front of me. I was looking forward to that as my next major recreational activity. That got me into an unexpected acceptance into medical school. I put my applications out there as this, early 30s kid that didn't really have the background for it, felt like I didn't really deserve it, but felt like I really wanted to give back, and put my applications out, and writ large saw phenomenal feedback from the community, and everybody wanted to give me the opportunity, and I thought that I had no chance in hell. So there I was in medical school, in a whole new ground, in a whole new capacity. I'm trying to teach myself and keep up with my peers with unexpected expectations that I didn't want my patients to have any difference between having a doctor in a wheelchair versus having a doctor that's standing by the bedside. And in the beginning, it was interesting. I had kind of a dichotomy of patients. Some patients would look at me and say, oh, well, this guy sees, is dealing with tragedy, so they'll immediately open up to me about the most intimate things. And well, meanwhile, my classmates are like, I can't pull water out of this rock that's in the room. And then I had the other cohort of patients that are like, well, I'm not going to complain to this guy. He's clearly got something going on. So I had to, massage both of those two different patient populations and learn, how to connect with everybody. And that kind of was a benefit for me, because it helped me feel like I was actually giving back, to learn the lives of all the patients I was treating. And of course, I had to adapt. As somebody in a wheelchair, you have to learn and how to overcome. So I had a standing device designed in Turkey that I, changed to be able to use for intubations and interventions, and we're able to make it fully sterile by putting drapes over top of it, and got a chance to go to a level 1 trauma center. So I was working on some of the most, emergent cases, which brought me full circle back to where I started in combat rescue. And all the meanwhile, my sister, who I had mentioned earlier, was going through an unexpected divorce. So I had her and her 3 kids move in with me. And this is the youngest of the 3. So I got to do my pediatric rotation every time I came home. So I was raising the kids, all meanwhile going to school and trying to figure myself out. So it was an interesting path for me. So what brings me here to be able to talk to you today? I can give a little bit of perspective, both as the patient and as a caregiver. So I thought that maybe I can give a few nuggets of information that might help you guys out. When I was given the opportunity to dive for the first time with Diveheart, I was suffering with intense pain all day long. I didn't want to be on any of the muscle relaxants or any of the pain treatments because I wouldn't be able to study and go through medical school. So I just kind of grit my teeth and bear it. I never wanted to talk about it with anybody because it was my own choice. I didn't want to have sympathy. I didn't want anything else. But what I equate it to is like you're taking a very long flight. And at the end of it, you really just want to stand up and stretch out. You just feel uncomfortable all day long. I don't really have the opportunity to do that. I can't get up, stretch out, twist, do all the things that we need to do to keep our bodies healthy. So it wears on the back of your mind at the end of the day. And scuba diving for the first time with Jim gave me this sense of almost confusion. I had no idea why, but I felt for the first time in my life different. After my first dive, I was finally starting to put it together when I got back to the surface. I couldn't place what it was that was different because this part of my life that has been there for 20 years was gone, and it was the pain. Having my entire spinal column fused from T2 to T10 and in the front from T4 to 7, I've got so much metal in me and rods holding me together. I'm some kind of a government experiment at this point. It was the first time that I finally felt back to being myself. That feeling wasn't just a fleeting moment. It lasted for weeks on end. And it was interesting to me. So marrying the aspect of spinal cord injured patient and diving seemed to be something that was a potential for us to use as a treatment modality in the future. Given all the free time I had in medical school and residency and fellowship, I didn't have the opportunity to follow up on this. But now that I'm through all my training, it's something that I want to get back into doing now. So I had this, as I mentioned, neutral buoyancy euphoria. It felt that weightless feeling of taking all the pressure and compression off my spine. Maybe it helped some of the neurogenic flow. At this point, we're only, with an N of 1, we're only guessing at what the pathophysiology could have been. But I did know that from personal experience, I felt like a world different than what I normally experience. We're going to go into a little bit more of the GI complications later, so I'll spare you the majority of the details, as our next speaker will probably cover some of this. But for me in specific, I noticed that my bladder volumes go up after scuba diving, which for us is a massive, massive change. I have the only 3 medications I'm on are the anticholinergics and an antimuscarinic in order to relax the bladder spasms, because we have bladder dyssynergia as the bladder and sphincter dyssynergia as paraplegics. And for me, if I have bladder tone from all the spasticity of having a motor incomplete injury, it's going to have a smaller vesicle, so therefore all of the urine is going to back up into my kidneys, and I could die of urosepsis if I don't treat that. Well, obviously we intermittent catheterize and do all these things, but for us a challenge is trying to continually catheterize and keep your bladder volume low so that your urine doesn't back up. Well, after scuba diving, the bladder can relax and expand. So it reduces my bladder tone. I don't have as much spasticity. So I noticed that all of my spasms while I'm scuba diving are almost gone. My body relaxes. I don't have any of the compression on the nerves. So it's just been an absolute bliss experience for me. And obviously, any of the gastroenterological issues, you're sitting in a cramped, tight posture in a wheelchair all day long without the ability to stretch and move and do all these things. Well, now you go into a weightless environment and you can allow your legs to fully extend and have the muscles relaxed so they're not spasming all the time. It takes a lot of that compression off your GI tract and allows a little bit better motility throughout. Now onto the testable portion. If there's anything that I wanted people to focus on throughout this lecture, it's not me. It's not anything that I went through personally, but how can we treat patients moving forward? And if you guys are ever diving and you come across somebody that has a neurological injury at or above they say T5 to T7, so we guesstimate T6, but none of the patients read the textbook. We all kind of present slightly differently. Some people might be assessed at a neuro-complete, might be neuro-incomplete, but they can vary. And for us, we'll just say at a roughly T6 level. we start seeing something called autonomic dysreflexia. And this is just a dyssynergia in between the various nervous systems we have, obviously the parasympathetic, the sympathetic, but also the enteric, which is also overlooked. Sympathetic nervous system can send triggers that are trying to get from below the level of the lesion in the spine up to the brain. Well, obviously the signal gets compromised somewhere therein, and the body goes into this mode where you're having a local sympathetic response below the level of injury with a parasympathetic response above the level of injury to compensate for that. So this dyssynergia or causes this hyperreflexivity from below, where you have tons of vagal tone trying to suppress the increased pressure, while meanwhile, below the level of injury, you have this vasoconstriction trying to push all of the blood back up to the head. And in a patient that can't really do much to compensate for themselves and may not be aware of what's going on because they may be asensate or have some kind of other mentation issues going on, having been in a brain injury or a spinal cord injury, they're not going to be aware of a lot of these symptoms. The onset of these can be triggered by any noxious stimuli, and that is a very broad statement because none of us really know what might be the precipitating factor. Among the triggers, some of the most common are the bladder and the bowel. So we would think that some of these noxious stimuli could be something as common as a UTI, as a distended bladder, could be renal stones, could be any number of things related, but that enteric signal from either the GI or GU systems are not getting back up to the brain, so they trigger this vasoconstrictive response. For gastrointestinal, we want to consider impactions, gastritis. If somebody that's coming down here to Mexico diving for the first time might be eating things that are different. They might be experiencing things that are different. They might have travel-related issues. So we got to kind of put all kinds of things in the differential and just open the mind to it a little bit because their life is a little bit different when they're out here diving. A lot of the other triggers in here, I'm going to say, are a little bit cryptogenic or more ambiguous because they're masked in individuals that are paralyzed. Now, we can see pressure ulcers, menstruation sometimes can trigger it, ingrown toenails, shoelaces, sunburns, rashes, any number of things that might be, the onset factor. And you can basically break these down into the B's. First is bowel and bladder, then is breakdown of skin, bones, and for lack of a better term, baby-related things. So menstruation could be undetected pregnancies, any number of things in our female patients. Bones are difficult to assess in a paraplegic. If they're not overtly fractured, the patient may not be complaining of experiencing pain, but their body will sense it, try to send the signal back up because the signal's compromised. The brain can't process it, so you have this dysreflexic response. Emboli, obviously, in diving is even more of a risk factor for us, so we got to think of these as well. And you could have a complexity of things. You could have a fracture that causes a emboli, and you might be dealing with two things at once. And then obviously, patients that are neuro-incomplete can't regulate their body temperature the same. So we got to consider hyper and hypothermia. They are starting off in a hot environment, going down to a cool environment with a weight of the ocean underneath them. Their body temperature is dropping. So these vast changes are going to be causing responses that the body can't really process easily. And this is in fact a medical emergency, and not to make it super dramatic, but the sequelae and natural history of this can eventually lead to death, but fortunately it's rare. You can cause myocardial ischemia, cerebral hemorrhage, stroke, seizures, all alike. So some of the symptoms, as I mentioned before, they were cryptogenic because we have the long laundry list here, and I'm not going to bore you with many of the details, but I'll show you some of the ways that these can be tricky to spot. So you got a paraplegic that's out in the summer sun, and they're just come back from scuba diving, and they start having confused mentation or something along this line. You're going to be looking for sweating. Well, they just came out of the water. They're going to be wet. How can you tell what's sweat and what's not? Skin flushing. Well, they're out in the summer sun. Is it a sunburn or is it skin flushing? So one I put on there that is a little bit innocuous. You won't find it on many of the tables, but it's skin itching. You'll see the patients that are like tugging at their skin, maybe not overtly pruritus, but it feels like their skin is warm and flush. And because of this, you'll see them touching themselves before they even recognize that there's the symptoms going on, because you can look on areas where the sun won't go, underneath the chin, for example, maybe it's behind an ear or something where the sun isn't beating, and then all of a sudden you see the flushing where you see them being agitated and getting at. Obviously goosebumps, well, if they're wearing a wetsuit, you're not going to see this. Cold skin, well, they just got out of the water. Then there's a cold ambient wind going on, so they're going to be cold. Stuffy nose, well, we just came back from diving. That might not be overt in anybody that's got clear sinuses from, coming up with the pressure changes. So you can see this is something that you're going to have to put a little bit more clinical acumen and look at the situation, not just the laundry list of symptoms that might be there. So what do we do to treat it? One of the things that is most important immediately is get the patient into orthostatic posture. Try to get some of the pressure going gravitationally, at least back down to their feet. We don't want them to lay down and relax. We got to get their head up and get some of the pressure out of the head, since that's one of the problems that are causing this color we mentioned earlier. Removing restrictive clothing. Well, this is going to be a huge one, right? Because we've got wetsuits on that are extremely compressive, and that's only furthering the problem of pushing all this pressure back up to the head. So the quicker we can get that wetsuit off, which is not an easy task for a paraplegic or a tetraplegic, the better they have at recovering. And luckily, most of these cases, once you find the noxious stimuli or the precipitating factor, resolved almost immediately. Assess the patient from toes to head. Obviously, the injury is coming from below the level of injury, so don't focus on the symptoms you're seeing. Focus on what the precipitating factor is. Start at the feet. They could have broken a toe putting their shoe on. You got people with lower bone density, so minor things might cause an injury to them that's not overt. And you want to look at all the skin on the way up. Could be anything from a bug bite, a rash, broken skin from ulcers. Any of these things. They're sitting on boats without cushions sometimes. They're transferring, they're doing things, and patients can can develop a pressure ulcer in as little as 10 minutes by sitting on a hard surface without a cushion. You have somebody that's asensate, they don't know that they're on a bony prominence. 10 minutes, you can develop a pressure ulcer. Obviously, as we mentioned, one of the most common was bowel and bladder, so you can do what you can on boat. Try to get them to avoid their bladder, either catheterize them or find a way for them to sensate to trigger a bladder spasm, and maybe that dyssynergia will go the other way and they'll empty their bladder. Obviously, dealing with the gastrointestinal system, that might be a thing that you want to get back to the hotel to do, but in an emergent situation, if it's a long boat ride, you might have to do some digital simulation or something and evacuate them in some way. And then finally, you can address their vitals. Because we have a mammalian dive reflex, changes in temperature could precipitate these symptoms for them. So consider this. Sometimes we might need to warm the patient, sometimes we might need to cool the patient. Consider warming and cooling modalities, and then if the systolic blood pressure remains above 150, then we can consider addressing them with medications. Obviously, we may not have those on the boat side, but you might want to consider those in the cases of unresolved pressure, because we want to avoid some of the more severe sequelae. That pretty much brings us to the end of autonomic dysreflexia. I hope you can kind of take a little different lens on just what the literature says. Obviously, there's a PubMed article you can read more, but I implore you to question me and pick my brain about some of the other specifics of this, because I've got personal experience dealing with paraplegia and know that myself, I don't present directly like the textbook says I would. So without further ado, thank you all of you for your time. And if you have any other questions, please, by all means, pick my brain now and or throughout the week. Thank you very much.